Well, thank you very much, and it's really a privilege to be here, and I'm just going to have a full disclosure. I don't have any corporate relationships, but I've only been in practice for 4.5 years. And one of the messages I want to tell you is that I was built up through an employed relationship in a hospital system, put through business school, and I had absolutely no idea what I was getting into when I went into private practice. It is a very steep learning curve, and some of the things I'm going to share from you today is really targeting around the issue of how do we recruit people into our specialty and how do we get them into private practice. And I am passionate at this stage of my career, having been employed, that private practice is the future of a lot of our specialty, and it will even, I believe, enhance what goes on in academic medicine. So as an overview, I would just like to build the case for why we should be having private practice expansion, and really understanding some of the challenges for recruiting and proposing some solutions. I guarantee you that some of you will be irritated with what I say because I think a lot of the issues we're having we've actually created, and it's just going to be a matter of rethinking it in a more creative way. But my thesis is we really are approaching an opportunity to expand independent private practice. In the state of Washington, where I'm from, Optum has come in and purchased the Everett Clinic. They've purchased the Poly Clinic, two large 100-year-old multi-specialty groups of over 200 doctors. They're now 3 years into it, and the doctors are miserable. And they're starting to leave in large numbers. I believe we can support academic medicine. I think that one target is new graduates. I think another target is going to be people like my colleague I spoke with at lunch who are leaving hospital employment and are looking for opportunities in private medicine. So just a little bit about my past. I finished my fellowship at Johns Hopkins. I was the first neurotology fellow there after training at Baylor. And Ron Coopersmith and Mike Sicard were the only junior residents who were ever my chief residents. I was actually head of them, but they told me what to do, and it was great. When I was at Virginia Mason, I very quickly ended up on the leadership ladder for the institution and ran the business development. It was called the Regional Clinicians Program. I went through a whole 3-year process of Toyota training in the Toyota Management School because that was going to be the answer to healthcare cost containment, was a lean program. And that was part of my training in the executive leadership. When I started a hearing center called the Listen for Life Center for Comprehensive Hearing and Cochlear Implants, raised about $3 million over a 5-year period. In 2010, my neurotology practice was just expanding too rapidly to be handled by the institution, and so I moved to Swedish to join a newly founded neuroscience institute because some of our neurosurgeons had moved over there. And it was not a pleasant exit out the door. I was very upfront about my negotiation with Swedish, but it took 90 seconds to get my name off the website for the Listen for Life Center that I created. 90 seconds, I actually looked, boom, I was off the website when they packed the paper box and escorted me out the back door. It was really not a pleasant experience for an organization I had given 13 years of my life to, and I felt I was very honest with. I went to the Swedish Neuroscience Institute, and I had the job of my career. I had neurosurgeons that were actually developing me as a surgeon, and we got involved in a Department of Justice investigation around the chairman of our department in neurosurgery. And it ended up with the entire C-suite being fired, the board being dismissed, the chief of neurosurgery lost his medical license, and we were all left astray. What was very clear in that experience is, although they did put me through business school, I was targeted as a regional CEO for the Providence system. I was interviewing for the CEO for the Oregon province at the time, which is about a 20-hospital system. When it came push come to shove, my assigned attorney wasn't there to defend me. My assigned attorney was to defend the institution I was working for. And I had to obtain my own legal counsel. I wasn't even a person of interest, and I can't imagine what it was like to be a person of interest with what I went through. And I actually ended up joining an ENT group, a 5-person ENT group up in Edmonds, Washington, that I had been leasing space from as an outreach clinic. And they're part of Proliant Surgeons. We have 250 surgeons. We have 140 orthopedic surgeons, and the rest of us are normal. I've been on the board since 2019. We have 32 practices and 18 ambulatory surgery centers in a hospital that is in a state that's a certificate of need state. So we've been targeted by private equity. They've actually tried to divide our group and take some of our groups to private equity. And the reason I say this is I have believed in every place I've worked. And what I believe now is every place I worked believes in themselves. And I think that in private practice medicine, by offering people the opportunity to be independent, to actually have responsibility for their practice. Things like, we don't need quality committees. We don't need efficiency committees. Because when you're in private practice, if you're not going to be busy. And we are nimble enough to be able to make decisions, and we can model this for our academic partners. We can support the academic programs along the way. And I think Mark is the perfect choice for the private practice study group, and I'm really proud of what he's doing. I'd also like to frame my private practice conversation on the slide that every talk I've been to in all of the leadership development in institutions revolves around, and that's the triple aim, where Medicare came out and said, we want to improve patient care, we want to improve access, and we want to reduce the per capita cost of health care. I can tell you that in no institution have I been have they achieved any of the three. And, but I do think that private practice is a vector to get there, and I'm pretty excited about it. So a couple things I'm going to throw out there for you, a couple of famous quotes. Albert Einstein, when he said, the significant problems of our time cannot be solved by the same thinking that created them. And the line below, young people just do not want to work as much as hard as we did. That's a quote I took from all of us in the room. So what about millennial physicians? Millennial physicians are millennial people. And millennial people think differently than baby boomers, which is what I am. And it's not bad. A lot of my millennial partners have taught me a lot about life, taught me how to play with a kayak on a Tuesday. Never done that before. I didn't know that you could actually play golf on Friday. But they have different priorities, and these are very important priorities to them. They really function, they want a career that has a job with social purpose and activism. And activism doesn't mean throwing rocks at police. Activism means they believe in something, they're going to endorse it, and they want you to care about what they care about with them, which is really important. Humans are the core to their story. Everything has to be about making somebody's life better. And even people who you think are totally off the rails, when you really talk to them, their intentions are really to try to help somebody in most cases. Wellness and work-life balance are built in their vocabulary. I used to be offended when we interviewed partners and their first question was, what time off do I get? And now if they don't ask me the question, I suggest it. Wellness is built into their mentality. And it's interesting that when you look at the post-COVID numbers, and this came out just this week in Becker's review, that otolaryngology, a frontline treatment in the emergency rooms during COVID, when we didn't know whether we were going to live or die or bring it home to our families because we didn't know what it was, had only a 37% reported burnout rate. Okay, emergency room physicians was 66%. So that means what we do has built-in purpose and is extraordinarily cool, and people like to do it, even though we were put in a bad situation. That was number 15 on the list of specialties. So what are some of the challenges that my fellows are facing? So I have a fellowship program, a one-year otology fellowship program, which is really built to send people back into private practice. So 8 of my 9 fellows have gone back into private practice. And they come to my office. Most of them are coming because they have not had enough cases in their residency. Major motivation for the shift into fellowships. So they get about 400, 425 cases and they go back. They function in general ENT with a expertise in otology. So they function in their private practice groups. They have higher debt loads than I experienced. They have lack of private practice exposure. And can I be a specialist in private practice is the most common question I get. Short versus long-term view. The short-term solution for somebody coming out of residency program with debt is to sign with a hospital. The long-term play goes against them. And how do we tell that story in a way that they can understand it? So I'll go through that in just a moment. The other thing that's really important and is driving some people into fellowship when they don't have to is they feel like they're not quite as prepared as they want to be. So if you go 2 years ago to my fellow, he lost 6 months of his residency, his chief year, to COVID. My current fellow lost 18 months and had a very truncated chief resident year. And these people are seeking fellowships to gain competence, to feel confident to go. Guess what? When you go into an academic environment, it is supposed that you're going to have mentorship to bring you along the way. I was at Johns Hopkins. I didn't see many people mentoring people. I saw people competing within the department. But do we have an opportunity as private practitioners to say, look, come join our practice, and we're going to glide you up to expertise? Because guess what? The majority of otolaryngology surgery in the United States is done in private practice settings. and a few of us are actually pretty good. The other thing is the recruitment process can be very intimidating. My fellow just signed a hospital-based contract without talking to me and didn't have a lawyer review the contract because the hospital told him that they'd reviewed it for him. Cost of entry balanced with debt is going to be a very significant problem. So what is the average medical school debt? And this is coming right off of the latest source I could find on the internet. And the average medical school debt is $241,600. Two of my last three fellows have been over $400,000 in debt when they came to me. That's a 177% increase. So if you look at when I graduated, I went to a private college, paid for it. I went to medical school and paid for it. I had $41,000 in debt. My fellow has 10 times that debt load. And he's entering a market where CPT codes are paying less. Fairly intimidating. 43% of those people had pre-med debt. So with fellowships, you have ACGME approved and non-ACGME approved. And people really do those for the two reasons I've stated. They want to become an expert in a tertiary setting, or they want to get more experience to go into private practice. How about a wild concept? How about being tertiary trained and functioning in a private practice environment? Sounds pretty cool. I do it every day. Options. You talk about a traditional academic model versus private practice, and that's the delineation. And when we heard earlier in the meeting that it's about 60% private practice, it's really about 62% people who are not in a traditional academic model is the definition of private practice. I'm not sure what the numbers are for independent private practice, but when you look at employed, multi-specialty group practice and hospital practices fall under that same category. So Virginia Mason for me and Swedish Hospital, those are the two examples I can give you. I consider private equity an employed relationship because right out of the gate, they start telling you what to do. And that's not what I would call independent private practice. I believe, and my thesis in my career is otolaryngologists should be able to pick the style they want to practice in and being able to do that and be successful. I think we can do it. Academic model. Can we fill the gaps in these academic departments? Why does an academic medical center have to employ all of their physicians? Why can't they have people from the community serving as the attendings on those cases? Are there creative ways we can look at that? We have patients, they have studies. We can help them with their research. We can help them with their funding. The limited work hours for residents has really been tough. It's actually lowered the number of cases that residents actually do. Now, I'm not saying that we should go back to the way we were all trained, most of us in the room, where nobody slept for 5 years. But I am saying that there are lower numbers, and that's a reality. It puts the whole idea of advertising your private practice with the built-in mentorship as having more meaning to a candidate. Some faculty don't have residents on their cases in academic settings. So now you've got people saying, I'm going to give up salary. I can't get my research funded because the NIH is funding at about the 9th percent right now in the hearing side. And now I don't even have residents scrubbing on my cases. Reimbursements challenges are challenging the strategies that have been propelling academic institutions for years. They've got the same financial squeeze we do. Can we help them? Maybe their faculties need to be smaller and they need to engage community doctors to fill those needs. Okay, I do 400 ear cases a year and the university does not send residents because they don't have enough people to cover their free flap service. Think about that. Hospital employed model. These are W-2 hospital employees. That's how I define them. So that would be a hospital employee, a Kaiser employee, negotiated salary, malpractice. You don't even hear about it. They just cover you. There's no real risk in walking out of that, except there may be a non-compete clause. Research may be available. We had a great research institution at the Swedish Neuroscience Institute. The only wealth you generate is your retirement plan. You're not going to be building any equity that when you retire could help support the early phases of your retirement. And I was just actually in a fly shop last week. Sage fly rods are really expensive, so I need some ancillary income before I retire. But the other thing is you're protected by the hospital team. I got to tell you, it was very uncomfortable when I got a call from the FBI to chat with me for lunch. And I found out that my lawyer was representing Swedish Medical Center. It was really ugly, and I wasn't even in trouble. Public Service Loan Repayment Program is a tool that the hospitals are using to bring new residents into their practices. And basically it says that if you are employed for 10 years in a nonprofit, which almost all of the Catholic healthcare systems that are driving $44 billion in revenue apiece are nonprofit. They're almost as crooked as the NFL in the regard of the use of nonprofit. But if you're employed by a nonprofit, including your residency years, for 10 years and you make 120 successive student loan payments, and they actually do a sliding scale on your student loan depending on your income. So my fellow through residency paid $100 a month, and he's still on track for 120 consecutive payments. They forgive the rest. So for him, he says the number is about $200,000 that will be forgiven. How fast can somebody make $200,000 in an ASC, in a private practice setting, if they're allowed to start making cash earlier in the process? I mean, that's a question we should be asking ourselves. The current administration actually expanded the qualifications for the loan repayment program, making it easier for people to get their loans repaid. I think it's a great program, but should it preclude somebody from choosing the practice style that they want? I hope not. There's some hospital problems that have come out. This is just this week's list of problems. United Healthcare Optum was blocked from buying Change Healthcare, which was a $13 billion acquisition, and it's a data collection company to allow them to compete in the risk market. It was ruled by the Department of Justice that it would give them an unfair advantage against other insurance companies. You know who drove this? The United States Hospital Association was key in getting that blocked. Providence Health, where I am, has just now been sued by the Attorney General of the state of Washington last Wednesday because they have not been providing community care. A Catholic-based health system is not providing charity care. And they sent out a list of how to answer the questions if the media calls you to all the medical staff. It was absolutely shocking. But anyway, practice acquisition, we heard about this. I thought Bill Blythe did a super job reviewing this. And I only show you this slide to kind of move it a little bit forward. So when you look at the Wall Street Journal, which is one of the single most utilized medical journals lately, 75% of physicians own their practice back in, I think it was 2013, 1983, and 46% of them own them in 2018. Just this year, Kathleen Blake, the VP of Healthcare Quality for the AMA, was, when they were initiating their their private practice initiative, said that hospital acquisitions have led to worse outcomes, and there's been no evidence that they've decreased readmission or mortality rates. There's no evidence that they've reduced. That she believed that it removed the immediate responsibility between the physician and the patient. And you're in private practice, if something happens to your patient, they're looking at you. They're not looking at an institution. And I think that really is important as we're developing relationships with patients on the long term. Physician unions. So this is just a summary of a bunch of slides I put together, basically saying physicians who are hospital employees or a collective organization like a Kaiser, they have the ability to strike. They can unionize. Physicians still in training, residents and fellows, they actually went through 2 runs of challenges going back to the 1999 Boston Medical Center case and then the St. Barnabas case in 2010, and they have actually been given the ability to organize, and they have joined in the United States. There's now a large SEIU-driven resident and fellow union that's going on. I flew here on Wednesday night with my daughter's friend who was joining us for the week, and she is working for a consulting company at Children's Hospital in Seattle. And she said it was almost nauseating to watch the moms bringing in their bald children for chemotherapy with the residents protesting their salary at the front door of the hospital. She said it really rattled her cage when she walked out. Is that our image of American medicine? So independent physicians who try to unionize are in violation of antitrust laws. So we can't unionize. That would be considered collusion. So this is the resident unrest that's got 2 phases. There was a 15-minute unity break in 2019 when the residents got together as just a unified house staff, and they all stepped out of the major medical center affiliates for 15 minutes. And they have now unionized with SEIU, and they walked out formally on Wednesday. And what's very interesting is their argument is a lot of the stresses of COVID were shifted to the house staff. So they were losing nurses, they were losing orderlies, losing people moving patients around, so they just had the residents go do it. Not fair. But what's really interesting is the quote was that private practice could become a more active option than employment after graduation. While hospital contracts are lucrative in the first few years, physicians in private practice tend to have higher pay and more control over their care environment. We don't need to strike because we like what we do. Very, very powerful. So when there's all of this turmoil going on, I think it's really important that we stand there and take a good hard look at it and say, where's the opportunity? Because there is opportunity to improve medicine, protect our specialty, and drive private practice where it needs to go, and that's to the front. So private equity, typically, and I am not a private equity expert, but basically they do an initial purchase of your practice. They pay you usually about 70% of what you were earning for the 3 years as you achieve a second funding cycle. The real issues that have been raised for joining private equity is we have a hard time recruiting docs, we have contracting issues, and we really wanted to find a partner who shared our vision. And if you want to hear that answer, call the Polyclinic, 125-year-old organization, 285 doctors, bonded with Optum because they had a shared vision for patient care. There's 20% of the doctors left literally the month that their handcuffs were over. And the people at Polyclinic are miserable. There is no shared vision in private equity. Private equity is designed to make money. So I wouldn't expect that of them. Maybe you can find a partner, but I think that might be a little tough. So what about independent private practice? You maybe can organize into a TIN or a CIN. We're a single tax identity number at Proliant Surgeons. There's goods and bads to both. We do have self-governance. The beauty of Proliance, the beauty of independent medicine is that it's physician-driven and physician-run. The biggest problem with Proliance and the biggest problem with independent medicine is it's physician-run. And physicians need to come together to have a larger voice. And then we need to start looking for other partners. Like, what about the Ambulatory Surgery Center of America? What about people who have aligned goals with us as physicians that we can make a bigger lobby and have a bigger statement? The self-determined governance is extremely important. But I will tell you, there's risk in this business like I've never seen. And it is so intimidating when you get into it. And I got into it 4 years ago, and I would literally have lunch with my partner and say, could you please explain this to me? Explain to me our balance sheet. Explain to me our investments and how it's being depreciated, because it's not making any sense to me. And I've slowly figured it out. The beauty is there's multiple ways to channel income, and there's multiple ways to channel wealth after you retire in private practice that is not available in either of the other settings. And I don't think we talk about that enough. The other problem is you have to negotiate your own malpractice insurance as your group, but that's just part of the business. So what are the opportunities? I think it would be really interesting to work more with the academic medical centers. It was great seeing Rob Labadie here. He's a good friend. I think he's going to be a great chairman. I think Gene's going to make his program awesome with his partners participating. I think that's a great model. In our area, the university has shut out private practice completely, and we're working to get those doors reopened. But we can actually make academic programs stronger by filling gaps so they don't have to overhire. Our University of Washington has 9 laryngologists right now, 9 laryngologists. So half of them are doing general ENT in the community clinics. We have opportunities now with the private practice study group to sit back and say, okay, one question maybe we address, which they may or may not decide to do, is how can we augment our relationships with the academic medical centers and make them stronger? We need to train good residents. We want to hire them. And it's pretty cool to train residents. It's really fun having a fellow. We also need to make sure that in that process, residents, it's ensured that they know what their options are. We really had good private practice rotations at Baylor, and we had great times over lunch talking about private practice opportunities with guys, like Sam Weber and people who are great. I don't know that that's available to everybody. What about the transparency of our practice data? When we sit down with someone and we're interviewing for them for a job, does somebody actually sit down and walk through the pro forma with them of what their buy-in looks like? And then compare that to what it looks like if they get on their salary structure at the hospital system. Are we giving people data to make good decisions? And I think there's an opportunity there. I talked to Bob the other day about this, and the whole transition, which we'll talk about in just a second, of how you bring them up to speed financially is only one piece of it. How are you going to bring them up to speed clinically? Are you going to mentor them? Does your practice have a soul? Right now, the Proliance board, we're redoing the mission and vision of the company because we're a company without a soul. We're just a bunch of doctors trying to make money. If we have a social purpose and we really believe in it, we can recruit people who have that same social purpose. And I think that's really, really important. I think the roadmap to partnership is really an opportunity. And I'll tell you, in all of my job applications, when I came out of fellowship, only one person actually told me what he couldn't do for me. Roger Lindeman, the CEO of Virginia Mason. And I went there because I felt like he was telling me the truth. And he did. And he couldn't deliver what he couldn't, and he delivered what he said he could. What about ways to soften the entry into private practice? Again, this would be a great issue for the private practice study group to look at. Is there a way to leverage some of the W-2 versus K-1 opportunities in your practice? Maybe they've got a salary guarantee that works up. They're a W-2 employee. And then if they're making their numbers, they pop into a K-1 situation, start getting more money from some of the other investments of the practice. What is the soul of your practice? What is your mission? I intentionally moved my surgery center back into downtown Seattle after the George Floyd riots. It may be the dumbest thing I've ever done, but I'm not giving up on the city. And people need revenue. They need a facility in town. It's amazing. We've lost no staff during COVID since we did that because they believe in the same thing. And we've not given them a raise yet, but we're going to bonus them. And again, programs can be developed in private practice, and I'll show you one in a minute. But what about some of these alternative tracks? So I've been brainstorming with our CEO about this, and this is the traditional path where you've got your compensation model. They typically earn in for a year or two, and then they have a buy-in. They actually write a check. The ASC is a separate entity. They can buy into that. Your ancillaries can also become, things that you purchase into, your audiology, allergy. And then there's the MSO, your central office. Real estate opportunities. Typically, people can buy in with shares. It's really hard to buy into anything when you have $400,000 in debt, and in 8 years your kid's going to go to college, and you're trying to buy a house in an expensive market. So this is for people who really have the cash to make an investment and buy in. So what about the guarantee track, where there's a salary guarantee, and you don't buy into anything until you're off your guarantee? But that does give you time to get your practice up to speed. Practice determines, you determine for that person their schedule, their time off. They're basically an employed physician, okay? The employed physician who is actually able to start getting into some of the ancillaries early will do better than their loan repayment program if you do this correctly. So we're looking at ways to do that because the risk is shared. The risk is shared with the practice. So what about the hybrid? Low guarantee with a bonus for RVU-based productivity. It can't be more lucrative than your traditional model. You don't want to penalize people who are buying in the traditional way. ASC shares, so what we're doing now, we dropped our buy-in to our practice, and our new partners are getting a 0.25 at the ASC at the get-go, so they can start making money and paying their loans. Because it's more important to me that the ASC has a longevity and gets me my buyout. And if giving money up on the front side does that, I consider that an investment in my partner, and I consider that an investment in otolaryngology. The vesting schedule to full share at the ASC is determined, ahead of time, and really they start vesting ancillaries as they get more productive in those ancillaries. And so that still provides protection, still rewards the partners, but there is a give. You are giving up some money, you are taking risk, they're taking money, and they're assuming some risk. This is also a way to create some stickiness. This is like putting Velcro on them so they're not going to leave your practice. So again, no cash outlay, the buy-ins are earned in at that point, and they take longer. They don't take 3 to 5 years, they take 7 years to buy in. And again, the ancillary revenue is very important to them when we're talking about things like student loans. So additional possibilities, is there a way to be a partner before you're an owner? And a partner votes and has a say in what goes on in the organization. Some of our care centers actually had your percentage of vote equaled your percentage of share at the ASC. So we have people with a 0.25 vote. What is a 0.25 vote? I have no idea. So we changed that. But so as soon as people are there for a year, they can actually vote in the company, and they're not an owner yet, but they do have a say in what's going on. Is there a way to give them some cash along the way as they're driving revenue in the surgery center? So maybe they go 6 months with nothing, and then they start with a 0.25 share or whatever you decide. The company can provide upfront cash to help them for a loan down payment. I live in Seattle. It's very hard to buy a house. This is important to people. And we're actually doing this by taking loans off of our malpractice insurance plan that we own. Take a portion of the loan as a practice expense. If the loan becomes, and again, we're looking into this, we've got our lawyers working on it right now, but if that loan payment comes out of a practice expense, it's a before tax outlay for the fellow or for the new partner. And this can be done, we've looked at it. It also creates stickiness, because if they leave, they get the whole bill back. So very important. We'll take your risk, but you need to take some risk on it as well. And can we really ensure mentorship? And that requires really just sitting down and saying, what do you need, what's your plan, and what timelines are we going to use to check in to make sure you're progressing as you like? I think it's very reasonable to do. And program building is feasible. So this is a program that I built. I'm in private practice. It's a cochlear implant program. Started when I was at Virginia Mason, where I started in Alaska, by finding audiologists that would do all the pre and post work for a cochlear implant. They would fly to Seattle, get their cochlear implant, and go home. So they are insured and experienced surgeon. The audiology is closer to home. The cost is less. Kind of sounds like the triple aim, doesn't it? This is now expanded to the state of Washington. The three arrows is where I have clinics. And we've got people now coming from a 4.5-hour radius in the state of Washington with all of their care at home with the audiologists. I've gone and done seminars with local otolaryngologists to handle any acute issues. And our cochlear implant program went from 50 to 70 devices in my private office, just with this program. That's the triple aim. We're bringing care closer to home. This was easier to achieve in private practice than it was in the institution, because I didn't have all the encumbrances of the institutional policies, and it's totally legal. What about disruptors? By definition, disruptors blindside you on something that was so obvious that you didn't fix that they blindsided you. And so Mark Cuban got a cold email, he called it, from a 32-year-old radiologist in Denver, Colorado, about pharma and about how much his parents' medications were costing. So Cuban started a generic pharma company. You've probably heard about it. He has got his radar screen up on this transparency issue. And he was interviewed, again, this was in Becker's, and in the first year of the transparency requirement, they had issued 342 warnings to hospitals for not complying. Another statistic that came out that said 18% of hospitals in the United States had met transparency rules so far. 18%. So I think we're in a position to kind of guide the direction of this. I think we're in the direction to really have a lot of say. And if we don't do it, somebody else is gonna, because there's a lot of money in healthcare. And guys like Mark Cuban are pretty smart. So again, we're a bit of a target for disruption, and hopefully we won't be like Deputy Dog and shoot ourselves doing it. So in conclusion, I think private practice has an opportunity to grow. It has an opportunity to enhance academic medicine. It has a way to better train, it has a way to better train residents, and it has a way to protect our specialty. I think if you want to drive lower cost, better access, and higher quality, I think it's in your office more than it is in the office at the hospital. I really believe that. And I believe that because I've been in all three. And my passion, and I'm telling you, it is a passion. I believe private practice is going to be what really preserves the institution that I most respect, and that's otolaryngology. So again, take the time to understand the needs of your partners. I guarantee you somebody looking for a job who's 32 years old in Seattle has probably got a different perspective than someone looking for a job in Charlotte, North Carolina. So we got to understand that. And if they don't align philosophically, it doesn't matter how good they are, they're probably not going to stick. And that's you're good, I'm good, I just don't think this is a great place for you. But if they do stick, maybe we might learn something from them. And I think we need to listen as our colleagues look to leave employed positions. I'd love to hear from the folks that stepped out in Greenville on their experience. It's an amazing story when you hear it. And I think look to facilitate the ability to make people partners. Partners are different than owners. Partners feel like they're part of the game. Owners, you have to earn your way into that like anything else, like any other job or business. And I think the mentorship piece is really undervalued. And I think we have an ability to mentor on a local, on a practice, and on a national level. And I'm really encouraged with the private practice study group. And the other thing is just taken off like a rocket, and the conversations are very relevant. And I also think really sitting down, I talked to Bob about this a little bit, just really sitting down with your young partners and saying, look, this is what you can expect. And we'll probably get it 80% right because things will change over time. But at least they know what they're getting into. You're removing the fear factor, and you're giving them a target to really look at and achieve. And they know when they get there, they're going to be in good shape because you've run the numbers for them. So I guess in my concluding comment as I show you where I gas my boat in the summertime is we've got to move from an either or position. It's either academics or it's private practice to either and. I think we can help both. I think we can both grow from each other. And I think our specialty is the one to do it. And I'll close you with my greatest analogy. If you take an otolaryngologist and you suck out niceness and you inject, I want more money, you have more orthopedic partners. And I think that is something we need to value. Otolaryngologists like to get along. And I think if you look at who's taking over some of these large chancellorships, presidents of universities, you've got Carol Bradford, Doug Girard, Cliff McGarian, it's no mistake that otolaryngologists are getting those jobs because we're good people. Thank you.